A male 23-year-old came with the complaints of generalized weakness along with nausea associated with chest discomfort sometimes. ECG shown below on examination, his heart rate is increased. What would this suggestive of? What would this suggestive of? So, what is the answer here? And what is this ECG suggesting of? Either it's hypokalemia, hypocalcemia, hyperkalemia, or hypercalcemia. So here the clue words which I want you people to remember is just the generalized weakness, which is associated with nausea, and there is chest discomfort sometimes. The patient or a person, he might also can able to feel the increase or differentiation in his or her heart rate. As such, if it's a male, this is in her heart rate he can feel. So ECG changes are shown and they have mentioned that heart rate is also increased. So what is the answer here, people? So you can written in the chat box also so that I can able to understand how much you understood this. So either it's hypokalemia or either it's potassium less or increased, either it's calcium, it's less or increased. It's B. Svetlana is saying it's B, hypocalcemia. And if any other options, anyone would able to try any other answers? Yes, Ravindra, you're right. It is hyperkalemia. Why it is hyperkalemia? See, can you able to see this tall tented T waves? Can you able to see this tall tented T waves? So these are nothing but tall tented T waves. Yes, tall tinted T waves. So why it is so important to see the ECG part also, because it will include your medicine and it includes your physiology part also. So please remember this ECG part of tall tented T waves that is seen in your hyperkalemia. A bit note I wanted to give you people about this calcium levels also. So please you have a note. Calcium, if the level is decreased or if the level is increased, how do you get the differentiation? How do you get the differentiation? See, whenever if it is less than 8.5 milligrams per deciliter, we call it as hypocalcemia. And if it is more, then we call it as hypercalcemia, isn't it? So in the ECG, especially, what is the changes that you're going to have? You will have a lengthened ST segment. You will have a lengthened ST segment. This is what you will notify in hypocalcemia. Please remember, either there will be lengthened ST, you can say, or you can say even the QT segment, or you can say the QT segment also, which is being lengthened. Okay, but this will be seen in your hypocalcemia, please remember. And if hypercalcemia is concerned, you can never see the lengthening, but there will be shortening. Can you able to see this? There will be shortening, lesser than the normal segments. Shortened ST and QT segments. Okay, so this is the differentiation you're going to remember for our calcium. You're going to remember for our calcium. And we have seen for hyperkalemia already in our question. So one thing that is left, that is your hypokalemia. Hypokalemia. So what is important to see in hypokalemia? Please remember its causes are very, very important. The normal potassium levels are that is between 3.5 to 5.5 milliequivalent per liter. The normal levels are also so important for you to remember. Okay. You have to remember a mnemonic here, that is S. The mnemonic which you're going to remember here is S. So what is this S going to say? I'm going to inform you about the changes in the ECG and also the symptomatic part also. Right. So here, if at all we are going to see the person or a patient who is coming under the complaints of low levels of potassium, he or she will be lethargic. Okay, he or she will be lethargic, he or she will have limb cramps or a muscle cramps. Okay, and there will be low cardiac rhythms, or I could say arrhythmias also, dysrhythmias also. There will be low blood pressure. There will be low blood pressure. And sometimes there will be low respiration also. These they can able to, why we are discussing this, because they can give this in your case part and they can ask you in ECGs. There will be a shallow T wave. There will be a shallow T wave. That's what this S and L is going to represent. S and L is going to represent. S is nothing but your shallow T wave, where you can see this shallow in the ECG. Shallow T waves in the ECG, which predicts as hypokalemia. Very, very important to remember. Please remember this part, symptomatic part, and the ECG mentions also hypokalemia. And one more thing that I wanted to inform and to mention over here about hypokalemia and hyperkalemia, in the means of main differences. Whenever insulin levels are increased, that decreases your potassium levels. Please remember, this is going to help you in your medicine also. If at all insulin levels are increased, it's going to decrease your potassium levels, causing hypokalemia. So if at all decrease in insulin levels, that is going to make it vice versa. Then, whenever your aldosterone levels get increased, there will be hypokalemia, that is hyperaldosteronism. Any disease that leads to hyperaldosteronism, anyone knows? Hyperaldosteronism. Why we are discussing much about these electrolytes? Because these electrolytes have been repeatedly asked in our exams, right? So, in which disease you are going to see hyperaldosteronism? Any idea? Hyperaldosteronism. You can able to see hypoaldosteronism in, yes, no, that's in Crohn's disease. You can see hypoaldosteronism in Addison's disease. Very important. Addison's disease. This is in your Crohn's disease. So these are also important to remember about your hypokalemia and hyperkalemia. And one more important part, many times they have asked, whenever the patient or a person is having hypokalemia, there will be alkalosis. pH level will be more. And if at all a patient or a person is having hyperkalemia, there will be acidosis. So these are the main few important points in which you are not going to confuse, or you're not going to get confused in any means by conceptual understanding, or you're going to mug up. Nothing is important. You just remember these points in your end of the revision, that what is going to make what the outcome, which is going to have a decrease or increase in the electrolytes. Either it is in the ECG part, symptomatic part, metabolic part. That's it. Coming to the next question, in negative feedback gain is infinity in which of the following? Feedback gain is infinity in which of the following? Temperature control in hypothalamus, blood volume control by kidney, blood pressure control by baroreflex, and no such infinite feedback gain is not possible. Very right, Svetlana. It is blood volume control by kidney. Why it is important? So it itself showing a word infinity. In one and only mechanism, you can see feedback gain infinity, right? Always know infinity is nothing but in which you can say gain, that is correction by error. It's a normal physiological mechanism which you have to remember. If at all a system that is not going to leave any error, it is not effective. Okay, so whenever there is no error, Whenever there is no error, whenever the denominator is 0, it's going to give a infinity. The feedback will be infinity, right? So what I'm going to tell you, that correction, if at all it is not effective, then the error will not be rectified. Then feedback will not be attained. Either it's positive or it's a negative feedback. You're not going to attain your error, or you're not going to rectify the error. So it is completely zero. So whenever the denominator is zero, you're going to end up in infinity. So that's called as feedback infinity. One and only mechanism that's going to give a feedback infinity, that is your kidneys. And that will be given only by the blood volume along with the blood flow. Along with the blood flow. The mechanism of this constriction and dilation and all we will see further on. But as of now, please remember this part. As of now, please remember this part. Now, so here there is a reflex that is given whenever there is a fetus that's being getting contracted by the uterine contractions, baby pushes. This is an example of which kind of a feedback. This is an example of which kind of a feedback. See, there is an oxytocin release, baby pushes, cervix gets stretched, then again baby goes posterior, or else the posterior part of the pituitary gland gets stimulated, in which oxytocin will be released again. It's a kind of a cycle where it gives a feedback mechanism. What's the example of this feedback mechanism? Please remember, it's a positive feedback mechanism. Once in a while, they have given this question as a case and they have asked what is the mechanism that is underlined here. See, it's a kind of a positive feedback mechanism. Okay. So now one more negative feedback example I'm going to give you, that is temperature decrease and sensors. So whenever there is a sensor that's going to give stimuli the response that your temperature is decreased, that's going to decrease your blood flow, that will be the response, right? Then your temperature will be decreased, then there will be hypotension that will give the sensors information to increase the blood pressure, to increase the sweat. That's how your body's temperature will be normalized, body's temperature will be maintained. It will say that temperature is less, so that stimulus will give a response, so that temperature will be maintained. Temperature maintenance is completely a good example of a negative feedback mechanism. Important. How it's going to give a stimulation by your temperature sensor receptors. How it's going to respond? By your blood flow, by your shivering and sweating mechanism, which in turn gets increased to normalize the blood pressure. So this is the example of negative feedback mechanism. Simple examples, no need to go in depth, no need to go in detail, no need to get confused. Very simple to remember: negative, positive, infinity. That's it. Infinity, good example is your kidneys. Positive, good example is your baby and oxytocin release. Negative feedback mechanism, temperature. That's it. Now, coming to the next question, a high altitude oxygen tension in blood becomes low. This produces hyperventilation. Low oxygen tension produces hyperventilation by activating what? So what's the answer here? What's the answer here? So they are asking, if at all the person is in a high altitude, the tension, this oxygen tension becomes low, and that is the reason why the person feels a hyperventilation. And which activation of what receptors, what factor makes them to have a hyperventilation? So what's the answer here? Any idea? Central chemoreceptors, carotid and aortic bodies, baroreceptors, J receptors. Very nice. It is carotid and aortic bodies. So if at all you wanted to be very clear about all these receptors, you should know a bit, at least a bit about your central and peripheral chemoreceptors, right? See, these are your central and peripheral chemoreceptors. First, we will see about the peripheral chemoreceptors. Kiran, why you're saying C? C is your baroreceptors. Baroreceptors, always you can consider until and unless your heart rate or any cardiac mechanisms are there. Okay? cardiac mechanisms are there, then you can go with baroreceptors. Okay, so if we are speaking about low oxygen tensions and hyperventilation, which is related with your respiratory mechanism, that deals with chemoreceptors. Now you can have a confusion about central or peripheral in chemoreceptors. That gives you a clear idea. So peripheral chemoreceptors may we have carotid bodies and aortic bodies. Please remember, this is one of the question asked before. Carotid bodies are located in, remember, they will be activated by Herring's nerve of ninth cranial nerve. Which is the ninth cranial nerve? Herring's nerve of ninth cranial nerve. And aortic bodies are located in the arch of aorta by the 10th cranial nerve. Very, very important. By the 10th cranial nerve. So we might, what usually people do, they'll concentrate more on the difficult part, difficult conceptual ideas and concepts, and they leave the very easy part. Please, you people don't do that. Always leave the difficult one, if at all, if it is very difficult for you. Leave the difficult stuffs because last 1 month is left for you. Last 1 month is left for you. In this 1 month, you have to one and only concentrate on the stuff whichever you have done already. Don't even worry about the one which is difficult. Don't even worry about the subjects which is not clear. Even there might be a question in your exam which you have studied. So be very clear in that. So very few and simple concepts are to be clearly understood. So carotid bodies are in Herring's nerve of ninth cranial nerve. And also aortic bodies are in the 10th cranial nerve. So one more thing here I want you people to remember is aortic bodies are sensitive in O2 sensitive K plus channels. That's what many people will forget. In the exam hall, when you click the option, you will have a confusion. Either it's a potassium or sodium channels. Be very clear that it is not a sodium channel, but it is a potassium channel, O2 sensitive potassium channel. So these are the peripheral chemoreceptors. Okay. Now, so these receptors, these peripheral chemoreceptors are stimulated by few parts are there. Whenever your PCO2, partial pressure of carbon dioxide is increased, these chemoreceptors will activate. Whenever there is a H plus concentration increase, they'll activate. Whenever your oxygen is decreased, this is what we have been discussed. This is what your question also says. See, whenever there is a low oxygen tension, you will be hyperventilated. What is the reason? Just because of this decline in the PO2, you will have these receptors in these carotid and aortic bodies, which is going to activate your peripheral chemoreceptors. That's the reason why they are getting activated and they will try to equalize the oxygen levels. And when they will not be stimulated, there is always an exception part which you should remember. And whenever the exception part is there, you should clearly read the question also. So when it will not be stimulated, it is not stimulated whenever the patient or a person is having anemia. It is not stimulated whenever the person is having PCO2 that is decreased. It will not stimulated whenever there is involvement of carbon monoxide. Carbon monoxide. So these are the steps which you are going to remember until and unless peripheral chemoreceptors are concerned, right? So very easy and simple examples and concept, you have to keep it in your mind. So here few respirations are mentioned and it is given some areas, what happens and how does it involve in your centers, right? Why? We have spoken about peripheral chemoreceptors. If at all central chemoreceptors are concerned, they always have a part in medulla. That's why we call it as central chemoreceptors. We have important some part that is nothing but your pre-Botzinger complex. Pre-Botzinger complex. This is important in your central chemoreceptors. We have two groups in central chemoreceptors, DRG, that's your dorsal respiratory group, and VRG, that's your ventral respiratory group. DRG always combines with your inspiratory neurons. Okay, VRG will be involving with both inspiratory and expiratory neurons. If I'm speaking about the pons will have also two centers, that is your pneumotoxic center, important centers, pneumotoxic center and your apneustic center. Why we are giving importance to all these centers? Because if at all any lesions, any problem in any of these locations, then your respiration is going to be affected. Okay. In pneumotoxic center, if at all it is having any lesion, then you will have apneosis. Apneosis. There is no breathing at all there. Okay. This apneustic center will be having inspiratory neurons. So this is what it is given here. Any problem in your pons, it will lead to apneosis. So please remember the respiration part will be affected. There will be a stop in a separate region of respiration. Then again you will have an inspiration. Then again your respiration is stopped for a while. If any problem in your lesions in the midbrain, that will cause hyperventilation. Okay. So same like that, if your medulla is affected, we know that central chemoreceptors are present in the medulla. If complete medulla is having lesions, then totally respiratory arrest will be there. Then the patient will be under respiratory paralysis or the patient will have been died. So this is the few part about central chemoreceptors which you have to remember. Now, so respiratory patterns are there, and when you will have these respirations that has been given detailedly. See, Caney strokes respirations are seen in your congestive heart failure, COPD, uremia, and all of your connective tissue disorders. Along with that, whenever you have a lesions in bilateral hemispheres, especially you remember in your medulla midbrain. And hyperventilation, there will be complete respiratory failure. It will be in the midbrain. Apneustic breathing, just now we have seen whenever there is a problem in your pons or lesions in the pons. Cluster breathing, your lower pontine will be affected in cluster breathing. Cluster breathing means in the starting they'll have a higher manner of higher efforts of breathing, then it is suddenly lowered, then they have a higher manner of breathing, then suddenly lowered. Ataxic breathing, completely no respiration, then again they have a peak and surge of respiration, then completely no respiration. So these are the few breathing patterns which you have to remember. This will help you to solve some case questions. Done. So coming to the renal part of physiology, all of the following increases your GFR except. What's the answer? All of the following increases your GFR except. Increased blood pressure, afferent arteriolar dilation, afferent arteriolar dilation, and hyperalbuminemia. What's the answer here? Yes, hyperalbuminemia, because everything is going to increase your GFR. Only your albumins, increase in level of albumins will decrease the filtration. Will decrease the filtration by affecting the filtration barrier. So that's the reason GFR is decreased. GFR is decreased. Right. So here a few things you have to keep it in your mind. Whenever there is a glomerular filtration, either if it's your afferent arteriole or the efferent arteriole. See, this is your afferent arteriole and this is the efferent arteriole. First, we will speak about vasoconstriction. If suppose there is a vasoconstriction, then what happens to your renal plasma flow? What happens to your renal plasma flow? And what happens to your GFR? You're going to see me. If there is an afferent vasoconstriction, what is going to happen to your renal plasma flow? If at all there is a constriction, how the flow will be? Flow will be decreased. Even if flow is not there, then how can you expect GFR? So GFR will also be decreased. Now, coming to this part, if efferent vasoconstriction is there, what about renal plasma flow? What about renal plasma flow? Any idea? If at all efferent vasoconstriction is there, then also your renal plasma flow will be decreased. but your GFR primarily will be increased, then later it gets decreased. So this is what happens in your vasoconstriction condition of afferent and efferent arterioles. Now, if you consider about vasodilation, what happens to your renal plasma flow? Renal plasma flow and your GFR both are going to be increased. If it is a dilated one, see, if there is wholly dilated, then your flow will be more, then your GFR will also be more. So both of them will be increased in terms of afferent vasodilation. If efferent vasodilation is there, your renal plasma flow will be increased and GFR will be decreased. Renal plasma flow will be increased and GFR will be decreased. Remember this, only this part, a conceptual part in your mind, so that will be easy for you. No need to completely understand or by heart all the concepts in renal plasma flow and autoregulation. Just you have to remember afferent vasoconstriction, efferent vasoconstriction, afferent vasodilation, and efferent vasodilation. That's it. It will be decreased, when it will be decreased, and when it will be increased. That's it. The next question, a patient has the following ABG finding. pH is 7.3, PaCO2, that is partial pressure of carbon dioxide, is 48, bicarbonates are 30. Bicarbonates are 30. So what's the condition shown here? Respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So what you can able to see here? What's the answer here? See, pH, it's decreased, so we can say it's an acidosis part. Your PaCO2, the normal level will be 40. If it is decreased, then we'll say alkalosis. Now this is also in acidosis part. Here bicarbonates are normal, so it is respiratory acidosis. If at all the values are like this, if at all I'm saying bicarbonates are 20, PaCO2 is 40. Now what will be the answer? pH is 7.3, partial pressure of carbon dioxide is 40, bicarbonates are 20. Now it is also in acidosis part. Yes, it's in metabolic acidosis. There is also a compensatory mechanism. If you understand the compensatory mechanism, that is well and good. If you don't understand, please don't get worried about that. It is a bit a difficult one of compensatory mechanism. If you know metabolic acidosis, alkalosis, respiratory acidosis, alkalosis, that is completely fine. Now, next question, a 41-year-old patient palpitations, complains of palpitations, dizziness for past 2 weeks. And he is in case of hypertension under medication. On examination, he is having big swelling like appearance in between back of shoulders near the neck. His arms and legs were too thin with poor wound healing history. What is the suspected diagnosis? So what is the answer here? First, you just pick it out the clue points here. So what are all the clue points that you're getting here? One is hypertension, that is under medication. One is he is having a swelling in his shoulders. One is having a poor wound healing history. This is what you're going to take as a clue. So if at all you consider hormonal disturbances, then only they'll have dizziness, hypertension, and all other symptomatic issues also. Very right. And you have given all the answers right. That is Cushing's disease. That is Cushing's disease. Why this leads to Cushing's disease? Any importance? How does this lead to Cushing's disease? What is the main diagnostic criteria? We have diagnosed this as Cushing's disease. One thing, there is a big swelling. This shows this is nothing but a buffalo hump. Very important clinical criteria. A very important clinical criteria that shows Cushing's syndrome or Cushing's disease. How will you differentiate between these hormonal diseases? That is main thing that you wanted to know about Cushing's disease and the syndrome, Cushing syndrome. One part disease, this is mainly due to a tumor in the pituitary gland, right? This is due to tumor in the pituitary gland, and especially that is going to produce ACTH very, very higher amounts, in a very, very higher amounts. Just because of this, your cortisol hormone is also going to be released more. So this is the main part of Cushing's disease. If at all syndrome is considered, any external cause, any external cause can increase the cortisol level, can increase the cortisol hormone levels that leads to Cushing's syndrome. This is a simple understanding and definition of how do you understand the differences between them. Okay. In Cushing's disease, mainly your ACTH hormone, you have to understand when it will get produced and when it is getting higher. Especially this is a stress hormone which gets higher during stress. Please don't get stressed. You will end up in increase in level of ACTH and then you will end up in Cushing's disease also. So now main clinical features to see in Cushing's disease. Main clinical features to see in Cushing's disease. One, we said that hormonal levels are increased. One, you will have a hyperglycemia, increase in glucose level, and increase in sodium levels you have. And one more important clinical feature, slow wound healing history. From before itself, not only from recent times, from before itself, the patient will say slow wound healing history, and they'll have osteoporosis history. This will help you in medicine part, even though if it's not comes under physiology, this gives you an idea for medicine part. Right, slow wound healing history, osteoporosis, there will be a truncal obesity, and one more important feature, which is a buffalo hump, we have seen, and moon phase. Very, very important. In Cushing's disease, you'll have a moon phase, and even your blood pressure gets increased, and your potassium levels only will be decreased. Very important. Your potassium levels will be decreased. So these are the very important things until and unless your Cushing's disease is considered. So very important clinical features to be remembered. Right. This salt and water retention, this sodium, increase in sodium disturbs the salt and water retention. Salt and water retention. That's why you are having an edema that end up in moon phase. That's facial edema. Especially the patient will have facial edema. So these are the few important factors that you should be very aware about if Cushing's disease is considered. Okay, fine. And same like this, we should know about the Addison's disease also. With simple clue I'll be giving you here so that you will understand the Addison's disease part also. Because both of the diseases are important in medicine, and you should find the difference between both of them. So in Addison's disease, it's completely different. It's a primary adrenal insufficiency. There you have a cortisol level disturbances that is completely increased. In Addison's disease, there will be adrenal insufficiency in which hormonal levels get decreased. Low cortisol levels. This is we have been seeing in the first differences of hypo and hyperkalemia, isn't it? Yes. And one more thing, your glucose levels, that's your sugar level, will be decreased, but your potassium levels will be increased. There is a hypoaldosteronism, and blood pressure levels will also be decreased. There is a darkened skin for the patient, and they are completely thin, fragile, completely thin. This is a very important clinical feature between Addison's and Cushing's disease. And your sodium levels are completely low. So these gives a opposite feature of Cushing's and Addison's disease. Even sometimes this retention will make blood pressure fluctuation also, and there is low levels of temperature, low levels of symptomatic differences between Addison's and Cushing's disease. So remember about this, which helps you in solving the cases. Now coming to the next part, true about erythropoietin hormone. It acts to increase RBC by cell division. It's principally inactivated by the spleen. It is produced by the adrenal gland. The production is inhibited by theophylline. What's the answer here? What's the answer here? Acts to increase RBC by cell division. It is inactivated by the spleen. Any idea? It is produced by adrenal gland. Production is inhibited by theophylline. I think everyone are a bit confused. C, D, C, D. There is a confusion between C and D. Okay, the production is inhibited by theophylline. That's the reason they'll never ever prescribe this theophylline drug for the patient who are anemic, who are having low saturation, and who's having kidney disorders. Why kidney disorder patients are not being prescribed by theophylline? Because our EPO, erythropoietin hormone, where it is being produced, it's being produced by both of your kidney and liver, but especially 75% from your kidney in peritubular capillaries. Peritubular capillaries. Very, very important. And the main importance of erythropoietin, please remember, this is also your physiological part. They use an important receptor. That is your TK receptor. What's TK receptor? That's your tyrosinase or a tyrosine kinase receptor. Tyrosine kinase receptor, very important. This helps you in your pharmacology part also. Okay, they are going to increase transcription and translation process. Transcription and translation process. They are going to increase the protein production, protein formation. That's why they are going to help in your RBC formation. So especially in CKD patient, that's your chronic kidney diseases patient, this EPO will not be produced properly just because they'll have a destruction in peritubular capillaries. That's why CKD patient end up in anemia, because these are important for producing RBC. Okay, so few importance of erythropoietin are given here. Remember, this theophylline drug is going to inhibit the production of erythropoietin hormone. So this is very, very important. Fine. The next question, an 8-year-old boy frequently comes to the clinic for persistent skin infections that do not heal within a normal time frame. He had a normal recovery from the measles. A check of his antibodies after immunizations yielded normal antibody response. A defect in which of the following cells would likely to be the cause? So which cell defective is the likely cause of his persistent skin infections? Two clues here you're going to get. One is your persistent skin infection. One, he is recovered from his measles and his antibodies are having a good response. So what's the answer here? Which defect of cells might be there? Which cell defect will be here? Either B lymphocytes, plasma cells, neutrophils, or any other cell defect will be here. Even if it is wrong, no issues. If you put it in the chat box, then I can know that what is the exact thing that's going on in your mind. Okay. A, B, I'm getting multiple answers. Try to be more active, then the session will be active. Yes, good, I'm getting good response. So all are having a confusion between A, B, C. So remember, always your persistent skin infection will completely depend on your neutrophils only. It completely depends on your neutrophils. Why so? Because they are the most abundant cells. Because they are the most abundant cells present. And these are the main markers of phagocytosis. So easily it gets triggered. They are the markers of phagocytosis. And any pyogenic infection you could able to first get identified by your neutrophils. Okay, and also you all know that it is the first line of defense mechanism, and you also know it's the first line of defense mechanism. And one more thing, this structure also you have to remember, please, because many a times in exams they'll give a slide and they'll ask whether what is the kind of a cell that is presented here, either it's a neutrophil, basophil, or eosinophil. You have to find it out. So that's what given here. Okay, sometimes if it is increased, sometimes if it is increased, it might predict also a hyperactive marrow. Hyperactive marrow. Your bone marrows are hyperactive. If this hyperactive marrow is there, then the examples or a disease that can be possible is hemorrhage or TB, like that. If the activity of neutrophils are decreased, then there will be hypoactivity of your marrow, causing especially anemias. Either it's aplastic anemia or pernicious anemia. Either aplastic anemia or pernicious anemia. Very, very important part. It might look something strange for you, but still, simple concept. If neutrophils are increased, it means your bone marrow is active too much. It on and only happens either in TB or in hemorrhage. If it is decreased, there is a hypoactivity in your marrow, in the production. It might happen in aplastic anemia or pernicious anemia. That's it. And one more thing about the cells. Yeah. So what is the cells that is shown here in the picture? What is the cells that's shown here in the picture? In pathology part also, it's important for you people to find it out the cells which is being given. So what is the cells that's given here? Are you sure it's eosinophils? Any other, any other guess? Any other guess? Hyper-segmented neutrophils. In-depth thought was there. I appreciate it. What is this? Either eosinophil, basophil, neutrophils. It's your basophil. It's your basophil. Please remember, it's your basophils. Okay. By seeing itself, you have to get the point how the cells get looks like in the ends, in the outlining structure. Also, you'll have a cell without leaving the inner part. If it's multi-lobe like this, then it will be your neutrophil. Then it will be a neutrophil. Right. So this is a multi-lobe structure which is showing neutrophil. So here a few structures are being given. How to find it out? Your blue for basophil. So only will your basophil will looks like blue, or all the cells will look blue in the dye. All of your cells will look separately in the dye which they add to test the cells. So eosinophil is bilobated. Basophils are also bilobated, but the inner part will be a bit broader so that you can differentiate between basophil and eosinophil. Neutrophils are multilobated. If it completely covers the lymphocyte, whole the cell, then it is your lymphocyte. If it's non-structurable, then it is monocyte. Very simple. Coming to the next question, all of the following passes through dorsal column except proprioception, vibration, fine touch, and pain. So what's the answer here? Proprioception, vibration, fine touch, pain. Direct answer. The answer is pain. Why? Because it comes under lateral spinothalamic tract. Lateral spinothalamic tract. Okay. So the things which you have to keep in your mind about your dorsal column tract, that is DCT, dorsal column tract. Your fine touch will be there. Please remember, crude touch will never ever be included. Vibrations. Why not C? It's fine touch, yeah. It's fine touch. Your fine touch is included in your dorsal columns. So vibration, proprioception, any kind of a pressure, especially 2-point discrimination, tactile stimulation, tactile stimulation. All of them are involved in your dorsal column tract. And one more, two important good features are also there that is involved in your DCT, that is stereognosis and graphesthesia. What is stereognosis and graphesthesia? Anyone knows what is stereognosis and graphesthesia? Stereognosis means if you touch your mobile in the closed eyes and if you find it out what is the object, then that is called as stereognosis. Graphesthesia means by touching you can identify or read the stuffs. Like in olden days we had a game, right? In our back, some of our friend used to write and we find it out what's the alphabets. That is called as graphesthesia. Everything is possible just because of your dorsal column tract. Okay. And one more thing, in dorsal column tract, you have to remember, please, it's a uncrossed tract. Very, very important. It's a uncrossed tract. Then you can ask me, ma'am, where it will cross? It will cross nearly when it goes and touches the medulla. Nearly when it goes and touches the medulla or the cortex. It will never ever cross in your spinal cord. That's very important to understand. See, suppose there is a medulla here. This is your medulla. Okay. And if suppose there is a lesions below medulla in your DCT, and also there are lesions that are above medulla. So what is the difference that is going to give in the sensations? So always remember, lesions below the medulla, example, that is in your spinal cord. Any problem in the spinal cord that's going to affect your touch, that's loss of touch. There is loss of everything, loss of pressure, especially in the opposite side. Please remember this, especially in the opposite side. If lesions are below the medulla. Okay, so loss of touch in the opposite side will be in the medullary part, and also in the same side part is also there. That is lesions above the medulla. Very, very important part to understand. Where does these lesions causes opposite and the same side? This is only happening in the DCT, and this we can give the difference and example in your one and only important syndrome. What is the syndrome that's going to explain this? That is Brown-Sequard syndrome. Very important. Brown-Sequard syndrome. Why we are going to explain here? Because there is a hemisection of spinal cord. Hemisection of spinal cord. Any injury which causes this hemisection of spinal cord, except pain, temperature, and the crude touch, everything will be lost in this patient. And that too, same side, there will be all losses of touch and pressure. Why? Because in the spinal cord it is happening. So same side touch and pressure gets lost. In the opposite side, what happens? In the opposite side, your lateral spinal thalamic tract gets affected. That's why you have a loss of pain and temperature in the opposite side. So this is shows the Brown Sequence syndrome. Please remember, same side loss of touch and pressure, and opposite side loss of pain and temperature is nothing but your Brown Sequence syndrome. Very, very important. Ipsilateral, that is same side. Contralateral, that's your opposite side. That's showing, that's going to give you the difference of pain and temperature in the opposite side. Whenever there is a hemisection of spinal cord, Brown Sequence syndrome happens. Whenever I think someone's mic is on.
ഫിസിയോളജിയുടെ റിവിഷൻ നടന്നുകൊണ്ടിരിക്കും ഓൺലൈനായിട്ട്. പക്ഷെ അത് കുറെ സബ്ജക്ട്സ് ഒന്നും ഞാൻ പഠിക്കാത്ത കാരണം ഒന്നും അറിയത്തില്ല.
अरे जुम भैया माइक ऑफ कर लो.
Okay, fine. So this is a simple difference that how you can able to differentiate between the dorsal column tract and the spinothalamic tract. See, in the spinal cord there will be there is no crossing of fibers, so that's why we call it as uncrossed. But in the spinal cord, if they cross, then that is your spinothalamic tract. That's the simple difference which we wanted to inform you. And crude touch will be in your spinothalamic tract, and rest of the steps which we have discussed already. Now coming to the next question, all of the following are functions of parathyroid hormone except. All of the following are functions of parathyroid hormone except calcium absorption from GIT, phosphate absorption from GIT, mobilization of calcium and phosphate from bones to blood, and resorption of phosphate from kidney. So what's the answer here? Calcium absorption from GIT, phosphate absorption from GIT. Any answers? Quick answers. We have to see many more questions. D. Any other answers? C. Mobilization of calcium and phosphate bones to kidney. Until and unless if you are clear about parathyroid hormones, you will not get any confusions. See, first I'll explain you about the parathyroid hormone function easily. Then you will understand the answer. Sorry, understand the concept, and you can answer the answer also. So parathyroid hormone, especially regulation of calcium, is important. How it's regulating the calcium. The main part of parathyroid hormone, when it is get stimulated, it will be stimulated whenever your serum calcium is low. This is the main part when it's going to get stimulated. And whenever your phosphate is high, it will be stimulated. And whenever your magnesium is low, it's going to be stimulated. So this is the three important places when it gets stimulated. Okay. An important function of how this parathyroid hormone is going to regulate is they increases bone resorption, that we all know, right? That increases bone resorption. How it's going to increase it? In one way, that is by calcium and phosphate that's going to enter into the blood. By blood, they'll get resorbed. In another way, these calciums, they'll be coming from to the blood. Where they'll come to the blood? From GIT and also from your kidneys. See here, parathyroid hormone is important to increase the level of calcium in the blood from your GIT and kidneys. It is not involved in your phosphate. So that is why D is the answer here. Resorption of phosphate from kidney is not going to happen But resorption to bone is going to happen only from calcium, that is to especially from GIT and kidneys. Simple understanding, you can answer the even the difficult question also. If you are going to get the concept, even the simple concept in a difficult way, that's not going to help you. Please be very, very simplified in your all the concepts and all the revisions. Don't make yourself confused and stressed in the way that you're going to reach your exams. Okay, so you're going to increase the calcium resorption from the GIT and kidneys to the blood. In that means you're going to increase your bone resorption also. So this is the false option here. Option D, resorption of phosphate from kidney. Very, very simple. Right. So the next question, all of the following have one axon and many dendrites except. It's also easy, I think. It's a very general question. We have structure of neurons, that's unipolar neurons, bipolar neurons, multipolar neurons, and pseudo unipolar neurons. So what's the answer here? Spinal motor neuron, hippocampal pyramidal cells, cerebellar Purkinje cells, and invertebrate neurons. Quickly, any other options? What's the answer here? All of the following have one axon and many dendrites except A, C, C, A, any other. So if you know the examples of unipolar and bipolar, multipolar and pseudo unipolar, you can get it. So what is being asked here? One axon and many dendrites means in which in which type does it comes under? Which type they are speaking about? Here they are speaking about the multipolar neurons, isn't it? All of them are examples of multipolar neurons, but this is an example of unipolar neuron, that is invertebrates. Please remember, this is an example of unipolar neurons. See, this is what. One neuron, many dendrites, multipolar neurons. All of the above mentioned answers are example of this multipolar neurons. Unipolar neurons, good example is your invertebrates, which we have seen now. Bipolar neurons, your retina is the example. Pseudo unipolar neuron, your dorsal root of ganglia is example. Even if you don't know all the examples, just remember at least one example. Okay, right. Which of the following is true about the picture shown below? So what does this shift is having? What is this shift that is having, and which is true about this shift? I think here the arrow mark is missing. The arrow mark should be like this. So now you can able to answer. Arrow mark is like this. So what shift is this, and which is true about this shift? Answers? Very right, it is left shift. And what's the answer here? If left shift, it is acidosis or alkalosis? If left shift, it is completely alkalosis. Their pH is going to increase. So it is increased pH. It's left shift. Oxygen hemoglobin dissociation curve is one of the important topic that is to be discussed. Very simple concept that you're going to remember. Left shift, that is called as Haloden effect, right? Right shift, that is going to named as Bohr effect, right? Right shift, that is Bohr effect. Always there will be loading of oxygen in your left, loading of O2. Here there will be unloading of O2. Unloading of O2. O2 levels are higher in your left shift. O2 levels are lower in your left shift. Your carbon dioxide levels are vice versa, lower, and here it will be higher. pH levels are more, which shows that they are in an alkalosis mode. pH levels are low, that shows they are in an acidosis mode. So that's why this DKA, diabetic ketoacidosis, is an example of right shift. And also lactic acidosis, which is an example of right shift. Your 2,3-diphosphoglycerol, that is 2,3-DPG enzyme is going to get decreased. That's the reason your oxygen loading is increased. Okay. And 2,3-DPG is going to increase in right shift. This is a simple oxygen hemoglobin dissociation curve that you should remember at any means, right? So left shift, right shift, very important factors and very important terms that is being discussed. So any doubts in this of right and left shift? So when your 2,3-DPG increase, whenever your glycolysis is increased, whenever your glycolysis increased, you will end up in having lactic acidosis. Only lactic acid will be increased. Obviously, your temperature is also getting increased as the person is under metabolism. Right. Next simple question. A patient with HbA1c of 11.4, completely high. HbA1c 11.4 shows that the patient is a diabetic patient, has came to you in the clinic with severe pain in feet at night. Which nerve fibers are involved in this patient? Which nerve fibers are involved in this patient? Which nerve fibers are involved for pain? That is also very important here, which is discussed. A, alpha, beta, gamma, C. Any other answers? D, very right. I think one first question which all of the people give same answer and the correct answer. Yes, this is non-myelinated C fibers. I'm not going to take much of your time. A alpha, very simple thing. It's involved in your proprioception. So just make it in a simple part. A beta, that's going to help in your touch. A, this is not A beta, that is A delta. A gamma is going to help in your A gamma is going to help in your touch. This is going to help in your pain. See, this both are going to help in your pain. But main important thing, this is a fast pain fibers. They are slow pain fibers. There's a very important difference which you have to find. And all of them are myelinated. And this is a unmyelinated or non-myelinated nerve fibers. Unmyelinated or non-myelinated nerve fibers. Right. So next question, a 60-year-old known case of diabetes mellitus has been noticed on laboratory work, which is having microalbuminuria. What is the site of reabsorption of proteins in the ultrafiltrate? Where the proteins all get ultrafiltered? That's what they are asking. Where does the proteins all get ultrafiltered? Any answers? Proteins get ultrafiltered in? Yes, very, very right, Mahesh. That is proximal convoluted tubule. Whatever the question says, completely blindly, no need to read any question. If they ask about site of reabsorption, a maximum in presence or in absence, in anything else, your complete direct answer will be PCT, proximal convoluted tubule. Okay, this is the main site of maximum of reabsorption. Main site of maximum reabsorption. Except there is also some exceptions, no? So exceptions are there. Exceptions are your H plus and your magnesium also. This is not going to get reabsorbed in your PCT. Why? Because this magnesium is going to get reabsorbed in thick ALH, that is ascending loop of Henle. Thick ALH that's going to get reabsorbed. Your glucose is the one and only part that's going to get 100% reabsorbed. Okay, so very important point of PCT you have to remember like this. And regarding your descending loop of Henle, important. They are permeable to water. And they are impermeable to solutes. This also you have to remember. And your ascending loop of Henle is vice versa to this. They are impermeable to water and permeable to all the solutes like sodium, potassium, or any other solutes which is there. They'll be permeable. And any kind of a passive reabsorption happens here. If something is left during the absorption of your proximal convoluted tubule, that passive reabsorption is going to be performed in your ascending loop of Henle. All right. If I'm going to speak about your distal convoluted tubule, that is your distal tubule, there is two parts. I can speak about your early distal tubule. I can speak about late distal tubule, and there is collecting duct. I cannot go in detail, but I'm just touching all the important points as far as most the maximum I could do. So in early distal convoluted tubule, there is one important port, that is your sodium chloride port, right? Sodium chloride port, and this is inhibited by what? Which drugs? If your pharmacology is done, you can able to say which drugs are inhibited by this sodium chloride port. Which group of drugs is going to inhibit this sodium chloride port, which is working in early distal tubule? Any answers? Thiazide diuretics. Very right. Very right. That is thiazides. Thiazides. Right. In both of your late distal tubule and collecting duct, your hormones, many hormones are there that's going to work. That's your antidiuretic hormone. Antidiuretic hormone, your aldosterone, and your atrial natriuretic peptide. So everything starts with A, easily you can remember. Atrial natriuretic peptide, aldosterone, antidiuretic hormone. Especially this ADH. What is the importance of this ADH? This is for concentration of urine. Your concentrated urine is because of your antidiuretic. Very important. So these are the few points that I could cover it maximally in renal physiology. So one more thing I'll inform you here. There is two kinds of urine which I could say. That's one is hypotonic urine and one is hypertonic urine, which is the concentrated urine, isn't it? Hypotonic and hypertonic urine. So if hypotonic is concerned, means either one reason, if your ADH is less, your antidiuretic hormone is less, this is possible. Or sometimes your sodium chloride is reabsorbed more. Okay, this is reabsorbed somewhere else, making your urine so watery. This is a possibility. This is main possible reasons of hypotonic urine. When there will be hypertonic urine, either there will be dehydration, too much of dehydration, which makes your antidiuretic hormone to produce more. Because of these, your aquaporin channels will open. So please remember what is the channels in antidiuretic hormone, that is aquaporin channels, which increases water reabsorption. So that's why your urine is concentrated, that is hypertonic urine. Two important points to be remembered. Next question. This is about the late distal tubule. Very important point about the cells. See, there are two distinct important cells, that is principal cells and intercalated cells. Important point of principal cells that it will reabsorb sodium and H2O and they secrete potassium. Very, very important. And what is the importance of intercalated cells? They reabsorb potassium and bicarbonates and they secrete H plus. They are a vice versa. That's why these both cells are very good example of acid base balance. They are a very good example of acid base balance. Okay. So the next question, the best moving touch receptor. Which is the best moving touch receptor? Answer, which is the best moving touch receptor? Paucinian corpuscles, Mason's corpuscle, Meckel's disc, and Ruffini's ending. Which is the best moving touch receptor? Yes, very right. That is Mason's corpuscles. See, Mason's corpuscles, why they are a best moving touch receptors? Because they are rapidly adapting. Okay, 1 point. Even though it's a one-liner, a few things are very important to remember. Okay, and they have very low frequency. They'll adapt only in low frequency vibration, right? And one more important thing, in all of these options, who is going to have 2 point discrimination? 2 point discrimination is given by, it is censored also by your Mason's corpuscle. Please remember 2 points discrimination is also by your Mason's corpuscle. Very important. So these all about Paucinian corpuscle, Merkel's disc, Ruffini's ending, everything you have to remember. And about Paucinian corpuscles, it is also what to say, rapidly adapting, but it have high frequency vibration sensing capacity. High frequency vibration sensing capacity. And one more thing about Paucinian corpuscles, if you have to remember, they also sense the pressure. They also sense the pressure. About 2 point discrimination, I could say it is also given by your Meckel's disc, better than the Mason's corpuscles. But one thing is, this Meckel's disc is in your Braille's system. So that's why this 2 point discrimination is better understandable by your Merkel's disc. Merkel's disc. Because they are a slow adapting touch receptor. Slow adapting touch receptor. So Merkel's disc also have 2 point discrimination better than the Mason's corpuscle just because they are slow adapting touch receptor, which is used in the Braille system of blind. Why? It is located in epidermis, dermis, and all the layers of your receptors. So it is located in dermis and all the layers of epidermis also. That's why they have a 2 point discrimination. So this is what very important part about the touching receptors that you have to know. Now coming to the next question, which hormone, direct answer, which hormone helps in release of prolactin from anterior pituitary gland? Which hormone helps in release of prolactin from anterior pituitary gland? Thyrotropin releasing hormone, corticotropin releasing hormone, luteinizing hormone, follicle stimulating hormone. Someone said luteinizing hormone, option B. Why so? You're confused. Why thyrotropin? Why all at this? I think you all have been very confused in this last moments of exam, isn't it? It's thyrotropin A, B, C, D. Any other answers? It's nothing but your corticotropin releasing hormone, which is from your ACTH, adrenocorticotropin hormones. See, regarding prolactin, you have to remember a few points about the PRH, that is prolactin releasing hormone, prolactin releasing factor, that's your from your ACTH. Okay, and there is also an inhibiting factor also. Inhibiting factor also. Especially all know confusion. Uh-huh. Right. So prolactin inhibiting hormone is also there. So who is the prolactin inhibiting hormone? If you're going to study about prolactin, you have to know the inhibiting hormone also. Very important hormone. That is your dopamine. If at all your dopamine is increased, then you will have a prolactin levels that is decreased. Okay. And the main function of prolactin is milk production, that you all know, right? If milk production is concerned, then the reason will be prolactin. If milk ejection is concerned, then the reason will be oxytocin hormone. And even secretion responsibility also comes under prolactin. And the breast size increases during feeding because of hyperplasia of glands. That's also because of your prolactin hormone. When we are seeing about prolactin hormone, I need to explain you a few things about growth hormone also. Once last exam growth hormone questions are being asked. When it is increased and when it is decreased. Very few points I'll mention here. Whenever there is a non-rapid eye movement sleep, especially in the third stage and in the fourth stage, you will have an increased good growth hormone levels. In a rapid eye movement sleep, especially in the deep sleep, you will have a growth hormone levels that is less. So don't sleep very deeply. Okay. And in a deep sleep, especially of third and fourth part only, you will have increase in level, not in the first and second part. Whenever the person is in a hypoglycemia part, they'll have increase. These are the stimulus. These are the stimulus especially to increase the glucose levels. And hyperglycemia ideally is going to decrease the stimulus level. Right. When you can see the faster good growth hormone levels, when you exercise, when you fast, that is fasting, and whenever you are ill. Right. So whenever the person or a patient use glucocorticoids, their growth hormone gets decreased. And one more hormone that starts with GH. What is that hormone? That is ghrelin. That is important for the increase in level of growth hormone. And which is the growth inhibitory hormone? Growth hormone inhibitory hormone. Any idea how ghrelin is increasing the hormonal production? Same like that. One more hormone it is there that inhibits the growth hormone. What's that? That is your somatostatin. Very important. Yes, very right, Rakshita. That is somatostatin. That's growth hormone, inhibitory hormone. So very important. These are the few points. Please keep it in your mind while you read growth hormone. Okay. So one more tyrosine kinase receptor hormone I said you. Here I'm mentioning you again that these growth hormone works by which receptor? Tyrosine kinase receptor. So one more hormone that works by tyrosine kinase receptor, which is the hormone I have mentioned you before in the discussion. Anyone? Any idea? Same hormone which uses tyrosine kinase as a, yes, very right, Suresh, that is erythropoietin, very right. So here, especially the pathway that is going to use by growth hormone, very important, JAK-STAT pathway. This pathway is also used by your prolactin, also JAK-STAT pathway. Please remember this pathway. And this is the importance of growth hormone, just consider. Okay. Now coming to the next question. Eating of raw or uncooked meat can lead to the development of, what's the answer? Stimulation of neuromuscular junction, inhibition of neuromuscular junction, inhibition of motility of breast border of villi, stimulation of motility of breast border of villi. Very nice question and Kant. That is inhibition of neuromuscular junction. How? How? You are right, but how? There is a raw and uncooked meat. If you are saying it is going to inhibit the neuromuscular junction, it's a very simple thing. How does it going to work? Very right. Very right. That is ACH block. They are going to block your acetylcholine release. They are going to inhibit the neuromuscular junction receptors. Why it's happening? Because it is due to your meat that's having a botulinum toxin. That is having a botulinum toxin. Okay. Yeah, very right. This is the reason why the person will get inhibition of this neuromuscular junction receptors. Botulinum toxins will be released. Acetylcholine release will be blocked. Next question, easy question. Distension of the stomach happens in. Distension of the stomach happens in cephalic phase, gastric phase, intestinal phase, and all of the above. All of the above. Oh my God. Please remember, in cephalic phase, the function that is going to happen, like your parasympathetic function is going to happen. That's so true. Your saliva production will be more. That is also true. In cephalic phase, only food goes inside. That's it. Food will be entering inside the system. That's it. There will be no any distensions. It will not get into the stomach. But during your gastric phase, food goes inside the stomach. And once it goes inside the stomach, your vagus and your gastrin hormone release will make this distension in the stomach. Distension in the stomach to happen. Why? Because it is happening? Because of HCl secretion. Because of HCl secretion. That is why distension in the stomach only happens in gastric phase. Now coming to the intestinal phase, means it's not directly belongs with the food. It is there, but acid will be there in your duodenum. There will be function in the duodenum especially. And that will be because of importance of hormone secretin, CCP hormone, gastrointestinal peptide, vasoactive intestinal peptide. These hormones are involved. Here, what they will do in this, they will inhibit the HCl secretion and they'll increase or they'll activate the bicarbonate secretion. Very important to remember in this phase. That is intestinal phase. I'm saying you again, you can study many things, but only few things you can understand and you can keep in your mind. Only few things. That few things should be the wise things and wise concepts which you have to keep it in your mind. That's what those wise concepts which we are discussing now. It is not like that we are going to touch all the topics. We will touch only the simple stuffs which is going to give you a complete revision of what you have studied these many days. Okay. Whenever there is acid in the duodenum, whenever there is a HCl secretion that's going to get inhibited via which hormone? Via all these hormones, there is an important reflex that's going to come here. There is an important reflex that's going to come here, which makes this all thing to happen in the intestinal phase, especially. That reflex is nothing but enterogastric reflex. They can also ask you this. Enterogastric reflex happens in which phase? That is in your intestinal phase. That's in your intestinal phase. Okay. So this is what you have to remember in this distension of stomach part. GIT physiology have many things to understand and remember. So please make it revision thoroughly. Now, one more important question. Hypoxic hypoxia is seen in carbon monoxide poisoning, hydrogen cyanide poisoning, ischemia, AV shunt. Hypoxic hypoxia is seen in. Hypoxic hypoxia is seen in. Hypoxic hypoxia in the sense whenever oxygen levels get increased. Whenever oxygen levels get decreased. When oxygen levels get decreased? Any other answers? All are going with an answer of C and A. It means like ischemia and carbon monoxide poisoning. Ischemia, carbon monoxide poisoning. See here the answer is AV shunt. Whenever there is a arteriovenous shunt, there will be low level of oxygen causing hypoxic hypoxia. Answer is B. No, matlab, no, anyone, yeah, Aftab have given the answer D, AV shunt. I was about to say no one have given the answer. Great. So why CO poisoning is not there? Because CO poisoning, these makes your RBCs breakdown causing anemic hypoxia. See, especially a hypoxic hypoxia, O2 will be less, which makes hypoxia to happen. And when it will happen, if you go high altitude, or if the person have any lung diseases, your partial pressure of oxygen gets decreased, your partial pressure of carbon dioxide gets increased, your hemoglobin either will be normal or it will be increased. Okay. There is a possibility that cyanosis can be present. It's not compulsory, but it can be present. These are stimulated by all of our receptors. So two receptors we have studied, isn't it? Chemoreceptors. So these can be stimulated by our chemoreceptors. Seeing about the anemic hypoxia, you know that HB will be less obviously. Any other important things? Any anemia can cause anemic hypoxia, and very important, carbon monoxide poisoning can cause anemic hypoxia. And please remember, I said anemia will never ever stimulate your receptors. Very, very important. It will never stimulate your any receptors, cerebral or chemoreceptors. It will never stimulate. And make sure that there will be no cyanosis also. There will be no cyanosis also in your anemic hypoxia. Obviously, HB will be less, right? If at all seeing about the stagnant hypoxia, one thing, O2 will be normal, but the delivering capacity is decreased. The delivery is decreased. And one more thing, especially it is going to happen in your heart failure. There is a stagnancy. Heart failure means blood is not going to get pumped anywhere. Blood is not going to get delivered anywhere. It will be in a stagnant place where O2 will be there, but the capacity to deliver the O2 will not be there. It will be decreased. That's the reason you have a stagnancy causing hypoxia. Any clots, major clots, any hemorrhage, in this means also stagnant hypoxia can happen. It will stimulate all of our receptors. Important. It will stimulate all of our receptors completely. And cyanosis, we cannot comment on this. It can be present or it cannot be present also. The final hypoxia, histotoxic hypoxia. What about histotoxic hypoxia? We are going to remember main thing, that's a cyanide poisoning. Cyanide poisoning, why it's going to affect your cells? Histo itself, the meaning is cells. Cyanide poisoning is going to affect your cells. Okay. And even though it's a cyanide poisoning, you will not have any kind of a cyanosis in this histotoxic hypoxia, and everything will be normal. Your HB, your O2, your CO2, everything will be normal. One and only thing, your cells will be affected. Okay. And it also stimulates your chemoreceptors. I know it's getting late, but still, how much we can come with, like how maximum we can touch up, I'll touch it. Then we will wind it up. Right, as such, we have started after 8:30. So maximum stuff we'll touch and then we'll wind it up. This is also direct question. Beta 2 receptors. It relates with your pharmacology also. Beta 2 receptors action leading to hyperglycemia or hypoglycemia, which is being mediated by which of the following enzymes? Adenyl guanyl cyclase, phospholipase A2. It's a direct one line answer question. What's the answer? Beta 2 receptors action leading to hyperglycemia, hypoglycemia. Which of the following enzymes are included? Any other answers? Quick answers. It's a direct answers. If at all beta 2 receptors are involved, your adenyl cyclase only will be there for involvement either of your any kind of metabolisms are considered. Any kind of metabolisms are considered. Right. Next question. It is related to your GLUT receptors. A child with loose stools for 1 day presented to your OPD. On examination, the signs of dehydration was present and the child was given ORS. It facilitates glucose absorption through which of the following receptors? So, two clues you can get it from here. One, the child is having loose stools, child is having dehydration, and one more, they have given ORS. So, how the absorption will be? It's very right. SGLT1 is the one mode of absorption, and how we can differentiate it? We can differentiate it by SGLT1 that's going to work in your intestine, SGLT2 that's going to work in your kidney. That's it. You have to know about GLUT also. All the way, in all of your exams, anytime, GLUT, there will be one question regarding GLUT. GLUT1 regards with your brain, kidney, colon, placenta, and RBC. GLUT2, there will be liver, especially pancreatic beta cells, small intestine, and kidney. GLUT3 is there where you'll have brain, kidney, and placenta. GLUT4, heart, skeletal muscle, and adipose tissue. They have multiple times they have asked this adipose tissue only. GLUT5, small intestine is involved. Once they have not asked the small intestine, they have asked absorption of fructose is in. Remember fructose F for 5. And sodium dependent glucose transporter 1, especially this is for both small intestine and kidney, but majorly it is for only small intestine. SGLT2 is for kidneys. Okay. Now, what is this law states, and especially what is this law is saying? Increased heart rate leads to increased CO, cardiac output. Increased discharge leads to increased cardiac output. What is the answer? Increased venous return leads to increased cardiac output. Increased blood pressure leads to increased cardiac output. If at all you know what is this law, then only you can answer this. What is this law actually? What is this curve? Very right, Vishnu. This is increased venous return that leads to increased cardiac output. This is nothing but Frank Starling's curve or Frank Starling's law. Many things are involved in your Frank Starling's law or Frank Starling's what to say curve. Especially this curve is happening only because of your calcium ions. Remember that Whenever calcium ions are starting their action potential or contraction, your stroke volume is increased. This stroke volume increases your force of contraction in your heart. Especially this Frank-Starling law involves in your end diastolic volume also. If everything is increased, then your end diastolic volume is also getting increased. Sometimes too much of end diastolic volume increase can cause regurgitations. Can cause regurgitations. So this is the force of contraction, and that is the reason heart rate is also increased. So this stroke volume, why we are mentioning the stroke volume here? Stroke volume, when it can be increased until and unless your venous return is more. Then only they can pump and take over all of your volume of blood that is present in the ventricles in the one pump. So force of contraction is increased. This Frank-Starling law also obeys all the inotropic drugs. All the inotropic drugs which we use obeys in this Frank-Starling's law. Okay. Always venous return increases. Then because of this, your stroke volume increases. Because of this, your heart rate and your blood pressure also increases. Your gaseous exchange increase. Your pulmonary circulation also increases. This gives good and oxygen supply along with the blood supply. This is a short action of how Frank-Starling's law works. Inotropic drugs in the sense norepinephrine, epinephrine, dobutamine, dopamine, everything. This is how it's going to work. How they are going to work? They are going to work by beta 1 adrenergic receptors. Especially these receptors are going to activate our CAMPs, secondary messengers. They are going to activate your calcium. Then how this works on in your action of Frank-Starling's law. Okay. So very important to remember inotropic drugs and how does this heart rate gets increased, and this is what the law states. If venous return increases, cardiac output gets increased just because of all of your force of contraction and volume increases. One more thing now here I was supposed to explain is about the important part of law. One more law, that is Mary's law. Same like Frank-Starling's law, we have Mary's law. So this is only due to your baroreceptors. Whenever there is a problem and whenever there is a pathology, whenever there is a pathological problem in the cardiac complex, then you will have this Marley's law that is going to come into the picture. Here it says blood pressure is inversely proportional to heart rate. If blood pressure decreases, then it's going to increase your heart rate. If your blood pressure increases, that's going to decrease your heart rate. So this is your Marley's law that shows. Whenever if you see the patient, if you see a patient with a hypotension, they always have tachycardia. So hereafter, you just check the patient. Whenever you have a patient with hypotension, they always have tachycardia. Whenever a patient with hypertension, you will have heart rate which is completely decreased. This is due to this Mary's law because of the any kind of a baroreceptor. Any kind. It could be a thrombus, it could be a clot, or it could be any reason. Right. The next thing is a patient presented with severe watery diarrhea resembling that of groove stools, rice stools. Damage of which of the following structures is likely to be resulting in this diarrhea? So what is the answer here? Zona occludens, gap junctions, adherent junctions, and hemidesmosomes. Yes, very right. Zona occludens. Why? This is a kind of a tight junctions. This is a kind of a tight junction. How it is involved and what it is going to be importance having of the structure. See, zona occludens, these tight junctions will have occludin protein and claudin protein. These are present in your intestine, in your kidneys, and in your BBB. What is BBB? Blood-brain barrier. Whenever there is a cholera, especially because of this Vibrio cholerae, this is going to release a toxin that is going to affect your tight junctions. That is going to affect your tight junctions. So that is the reason. If suppose this is how they are arranged, if your tight junctions, then they have a intercellular gaps. Means there will be a disassembly of the junctions causing this diarrhea. And there is a gene in claudin protein. Please remember, they can ask you the name of the gene and the number of the gene. There is a 16 gene. Claudin 16 gene. Have you seen people or a person who always complains of diarrhea after food? He feels something like after food he is having a diarrhea. So this is because of mutation in this claudin 16 gene. Right. Come to the next question. A 37-year-old woman presents to her physician with an enlarged thyroid gland and plasma levels of T4 and T3. Which of the following is likely to be decreased? Her heart rate, cardiac output, peripheral vascular resistance, and ventilation rate. What is the answer here? Heart rate will be increased or decreased. They are asking which is going to be decreased. Simple thing, T3, T4 levels are elevated, glands are also elevated. Literally, it's going to speak about hyperthyroidism. In hyperthyroidism, everything will be increased. Your metabolism, your levels, and your weight, and it is your BMR which is getting increased. But your TSH levels will be decreased. In that means your heart rate is increased, your cardiac output is increased, your breathing is increased, which is ventilation rate, but your peripheral resistance is not going to get increased, that is going to get decreased. Okay. This is because of your metabolical reason. Coming to the next question, which are the following ions in the thick ascending limb of the loop of Henle responsible for the resorption of divalent ions? We have already seen about this ascending loop of Henle. I have already informed about this ascending loop of Henle to you. We have seen two things that is going to get absorbed in your ascending loop of Henle. That's one is your loop of Henle, which is responsible for the reabsorption of divalent ions. What is the answer here? Many mixed answers I can get. We are not speaking about the secretion, we are speaking about the resorption. Especially ascending loop of Henle, if we are speaking that is too thick ascending loop of Henle, please always think about potassium ions. Potassium, magnesium, the maximum which has been resorbed in ascending loop of Henle, which is left in proximal convoluted tubule. That is a divalent ion. So next question, easy question. See a case question. A 2-year-old boy bleeds excessively from minor injuries as previously bleeding gums. The maternal grandfather has a bleeding disorder also. The child's physical examination shows tenderness his knee with fluid accumulation in the joint. You suspect this patient with deficiency in which coagulation factor? So what's the answer here? Which coagulation factor deficiency is here? Yes, very right. That is factor 8. It's a kind of a hemophilia A. Hemophilia A. See, one and only clue. See, maternal grandfather has a bleeding disorder. Maternal grandfather means this boy will be having this disease only because of his mother. Mother is a carrier always. In hemophilias, females are always the carrier of the disease, not the sufferers of the disease. Males are always the sufferers of the disease. Can you see? Grandfather has suffered. Now his son is suffered. So this is how we can differentiate hemophilia. And clinical features, if I'm saying, there will be arthralgia, and also there will be bleeding disorders. Sometimes the patient or a person will have abdominal pain also. To differentiate hemophilia A and B. Few clotting factors I have given here. So I hope you people would know, and you also know the mnemonic for this, right? Foolish people try climbing long slopes. After Christmas, some people have fallen, isn't it? I have studied these mnemonics when I've been studying. I hope you might be having some other mnemonics, or if you have same mnemonics, that also well and good. But please remember the clotting factor's name also. Okay? Right. So main thing I wanted to mention here is your APTT, that is activated partial thromboplastin time increase will always intimate the intrinsic pathway disorders. Please remember this always. In clotting pathway, we have two, right? Intrinsic and extrinsic pathway. In intrinsic pathway, you will have involvement of 8th factor, 9, 10, 11, and 12th factor. So they'll have involvement of increase in activated partial thromboplastin time. If prothrombin time is increased, there is a problem in here, and there is a pathological issue in the extrinsic pathway. Any other external fastest injury will be there. Here the involved factors are 3 and 4 factor, which is in your common pathway. Common pathway from the 10th factor leads till your fibrin and the clot formation. Everything is your common pathway. So I want you people to remember PT increase in levels disturbances is due to your 3 and 4 clotting factors. APTT is because of your 8, 9, 10, 11, 12 clotting factors. Right. So the next question, all of the following increases the gastric acid secretion except. It's also a direct answer, one liner. Acetylcholine, parasympathetic nervous system, it's going to increase your gastric acid secretion. Histamine, there is a H2 receptors that is going to increase your gastric acid secretion. Gastric hormone, obviously it's going to increase your gastric acid secretion in gastric phase itself, right, which we have read already. So what will be the answer? The answer will be a serotonin, which is having no role in gastric acid secretion. Okay, so if you block the H2 receptors, any H2 receptor blockers, do you know any drugs that blocks H2? Any drugs that block H2 receptors? Any idea? H2 receptor blockers, I think all have slept. Or if anyone alive, then please answer. H2 receptor blocker drugs. If your pharmacology is clear, if you have done your pharmacology, then what are all the drugs, or any one of the drug you can say me, H2 receptor blockers, which blocks your gastric acid secretion? Yes, very right. Ranitidine, cimetidine, everything is going to. That's what available as Rantac and all. Fine. Okay, I do understand that you people are awake. Fine. One of the important topic, very important topic. Only few things, 2 or 3 important topics to be discussed. Rest of all the things are easy for you to remember only. High amplitude of A wave in jugular venous pressure. High amplitude of A wave in jugular venous pressure. So, which any one of the disease which you can able to got the point of A wave in jugular venous pressure. Either it's tricuspid stenosis, tricuspid regurgitation, bicuspid stenosis, that is mitral stenosis or mitral regurgitation. What's the answer here? First of all, you have to know what are all those waves are saying and what those waves intimate. See, you have A wave, C wave, X wave, V wave, and Y wave. All these happens whenever right atrial pressure decreases. All these happens whenever right atrial pressure increases. A wave is going to happen in your atrial systole. C wave is going to appear in your isovolumetric contraction, that's your ventricular contraction, right? And also V will be your atrial filling. V will be your atrial filling. And when will be your X and Y happens? X is during your ejection phase. Y is whenever your AV valve opens. So cardiac cycle is a big part which I cannot able to explain on the whole now, but to the maximum I'll try to make you people understand what's the thing that's going on here. Okay, so this is the basic thing that happens in jugular venous pressure: A wave, C wave, X, Y, and B. Here, if suppose there is a higher, larger wave, that is A wave, if it is there, then what will be the pathological thing? That's your tricuspid stenosis. That's your tricuspid stenosis. Few things are there that you have to keep it in your mind. See, if there is an absence in your A wave, means there is no right atrial pressure, there is no atrial contraction. That's why A waves are absent. So it only happens in your atrial fibrillation or in the tachycardia part, in which there is no complete rate of the heart. Flutter waves, in the sense either heart rate might be normal, sometimes heart rate might not be there, sometimes there will be too much pumping of the heart, leads to tachy also. This is called as atrial flutter. In ECG, you can see sawtooth P wave. Sawtooth P wave. And one more thing that we have seen now, that is larger A waves. Larger waves are seen in your tricuspid stenosis and pulmonary stenosis. If there is no X wave, then that leads to your tricuspid regurgitation. Larger CV waves can also lead to tricuspid regurgitation. And when cardiac tamponade can happen, once in a while they have asked this. If white descent wave is absent, then cardiac tamponade can happen. Can anyone say the triad of cardiac tamponade? Can anyone say the triad of cardiac tamponade? What is the triad of cardiac tamponade? I know in medicine there is cardiac tamponade and there is triad of cardiac tamponade. If anyone remembers, you can say the triad of cardiac tamponade. There will be hypotension, there will be jugular venous pressure, jugular venous distension will be there. When white descent will be absent means if suppose right atrial pressure is not decreased, if it's completely increased, then you will have tamponade, then you will have absence of white descent. In that means you will have a tamponade, completely a stuck heart. Completely a stuck heart. Anyone else who can able to say the triad of tamponade? I'll be waiting till last. I have given even a clue twice. Yeah, hypotension will be there then. Two more. Hypotension will be there. Yeah, that's right. Beck's triad. What is the triad that's involved in tamponade? One is hypotension, distended neck veins, that's jugular venous pressure is increased, distension of jugular venous pressures, you can see, and muffled heart sound. Very right, very right. So now I am a bit fine that you people are awake, right? Fine. So the next question, this we have already discussed. We are not going to spend much time here. Falls about the track depicted in the image. Falls about the track depicted in the image. 2-point discrimination, proprioception, vibration. Here we have DCT. In DCT, we don't have crude touch. That's the answer here. Right, very right. Whenever the bladder is oversensitive to infection, the most common type of incontinence happens is whenever there is a oversensitive to infection, because literally we are speaking here about UTI, that is urinary tract infection, there will be urge incontinence. There will be urge incontinence. Any infection, trauma, neurological disorders sometimes leads to urge incontinence. Stress incontinence especially happens in your trauma part. And overflow incontinence will be in a elderly people and in a very younger people as well. Very younger people as well, which we can say it as a nocturnal incontinence also. Nocturnal incontinence also. But here, one thing which you have to remember, that's your infection part that leads to urge incontinence, but they'll not been thinking about the urination all the way. Right. The next thing, sequence after P wave. I think these will not be given in the questions, but this is what you have to say. Sequence. What is the sequence after P wave? Either there will be A wave first, heart sound first, rapid filling of ventricles first, T wave first. What's the answer here? ABCD is the sequence, BACD is the sequence, ACBD is the sequence, or ADCB is the sequence. As such, we are running out of time. I'm not going to explain any cardiac cycles, just we are going to solve the questions. A means you're saying A, B, C, D. Means A wave, first heart sound. Do you think first heart sound comes in the first part only? We have clearly studied first heart sound comes in last only, right? The answer here is A, C, B, D. First A wave comes, then ventricle fills, then first heart sound comes, then T wave comes. Okay? Yes. So the next question is least frequency of basic electrical rhythm. First, you wanted to know what is basic electrical rhythm, then you can answer these questions because this cannot be wrong at any means. You know, in GIT, there is a pacemaker. Same like SA node, how we call it as pacemaker. Very right locate, that is cecum, that is having least frequency of BER. And here in GIT node, there is a pacemaker. There is a pacemaker. That is interstitial cells of Cajal. Interstitial cells of Cajal. In this, they are having in a layer where they use to produce a rhythm. This is the stimuli, like anything, your food or anything else, in which there is having no any spike. If you see the spike, then you can see the rhythm. This is a kind of a action potential. Because of this action potential and stimulus, you are having a rhythm that is called as basic electrical rhythm. This will be maintained in -40, -60, -40, all the way. Starting is your -60 from your action potential of neuron only. Everything happens by your action potential only. Only if the rhythm is there, there is no contractions. If there is no stimuli, there is no contraction. Without food, do you have any contraction or any rhythm? That's not going to happen. That's your basic electrical rhythm. So when you will have a contraction, whenever your basic electrical rhythm along with the stimulus is going to work, you will have a proper contractions. Either it's food, any drugs, any feces, anything else it could be. Then I said that you will have a action potential that's going to give us spikes. Obviously, any action potential will lead to release of calcium that causes contraction. This you have studied in your muscle physiology, that there will be a release of MLCK, myosin light chain kinase, which leads to coupling and contraction of muscles. This is how your whole of the rhythm happens. And this is how peristalsis happens. Only we cannot say that peristalsis is happening. How the peristalsis is happening, that is important, no? This is nothing but your peristalsis part. And if you say where does this calcium is coming from, it is coming from both your intracellular fluid and extracellular fluid. Coming from both intracellular and extracellular fluid. Always remember, without stimulus, nothing is going to happen. Either your food or fecal matter or any drugs or anything else. If stimuli is there, then peristalsis will happen. If no stimuli, then what is going to happen? Then there is an important part, that is your MMC. That is migratory motor complex. Migratory motor complex, very important to remember. Why this is happening? Because whenever you're not eating anything, whenever you are in a fasting condition, whenever you are in a postprandial condition, or whenever you're in a resting condition, this MMC is going to make the contractions. Because we know without stimuli, there's no contraction. Then how do you find the bowel movement? By this migratory motor complexes. Okay. If no stimuli, then no peristalsis. If food is there, there will be peristalsis. Fine. There is a simple question and the simple plot here. In the plot, the change is due to. In the plot, the change is due to. Here I is supposed to mention here something else. See, in the basic electrical rhythm, duodenum will have 12 per minute. Jejunum will have nothing like that, 8 per minute. This is the 31st question, which the wave is, this will be first A wave, then rapid filling of ventricles, then first heart sound, then your T wave. 8 per minute. Ileum will be having 9 per minute, and cecum will be having very less, that is 2 per minute. 2 minutes per minute. 2 frequencies per minute. Now, so this plot, this is nothing, this is showing about your fluid part. This is showing about your fluid part, what it is saying and what it is mean to be. Infusion of hypotonic saline, infusion of hypertonic saline, laws of hypotonic saline and laws of hypertonic saline. So what is the answer here? Any idea? If you understand the image, see there is something else, borders of fluid which is crossing that, levels also. There is a level of fluid plot that is crossing the border of the fluids whenever there is a loss or infusions. Like if at all the fluidity changes, the plot will change. If at all fluidity changes, the plot will change. If hypertonic saline means, you can able to see the plot like this. Everything will be stuck inside. Literally like this. You can see the plot like this. This will be nothing but hypertonic loss. Everything is loosely arranged. Everything is loosely arranged. The fluids will directly flush it out inside. The tonicity, the thickness, the concentration of the fluid will be in loss. Here, the plots are get so thick, there is no any place to go or any loose arrangements. So this is due to your loss of hypotonic saline makes this so thick and concentrated. Thick and concentrated plot. It's tightly arranged. The matters are tightly arranged. Even though if it's fluid, the plot shows the tightly arranged manner showing laws of hypotonic saline. So some difference which we can show for hypotonic and hypertonic saline. If at all there is an infusion, the graph will be like completely big. Everything will be completely big. Infusion doesn't even have nothing to say here, because either if you put something inside or if something is lost, then only the plot changes. Right? If hypertonicity lost, then the plot will be bigger. If hypotonicity is lost, then the plot will be concentrated, thick. Like how we have seen in the concentration of urine, same applies here also. But here we are seeing in the means of plots. That's it. Right. So next question, same like that, which we have seen before about our basic electrical rhythm, which we have studied. If no contractions, no stimuli, then there will be nothing else that is happening. There is only the means only the rhythms will be there, but there is no any spikes. You can see the spike only when there is a stimuli. If there is a stimuli, then obviously you will have an action potential. We have a marking in basic electrical rhythm. This is the marking that is shown as X. This is the marking that is shown as X. Okay. So here something else I have to mention. I'll mention here. In hypertonic saline, anyone knows the example of hypertonic saline? Very important example, that is a 10% mannitol. And important example of hypotonic saline or hypertonicity. Example will be 0.7% or 0.5% NaCl. Okay. Isotonic salines or isotonic fluids are normal RL fluid, normal NaCl, which is 0.9, which we give it as NS, or 5% dextrose, everything are isotonic saline. If we have to make that so loosely arranged, if the fluids are should not be in a concentrated mode, if it should be in a diluted mode, then you will prefer these fluids. If it should be so concentrated, then you prefer mannitol. Right? Any other doubt in these rhythms? One and only because of stimuli, you will have a basic electrical rhythm. Without stimuli, without action potential, nothing is going to happen. This spike shows the action potential only. That's why here the answer is action potential. Here the image is shown where higher levels are there in early morning. There is higher level in B, and it is gradually increasing in C in the early morning, means in the from the very night, from the midnight, I could say. And A is increasing in the medium manner. There is a lot of increase from the midnight, that's your 12 a.m. itself. Slow gradual increases there in C, and here maintained increase in A. So which hormone will be showing this kind of a pattern? What is the options that is given here, and which pattern can be seen like this? It's peaking in the 8 a.m. It's peaking in the early morning. It's peaking next to that. Like this it comes. The first peak is achieved by A. The second peak is achieved by B. The third peak is achieved by C only. So which possibility of hormones could be the reason here? Any idea? First, corticotropic releasing hormone. This is your CRH that it peaks very first in the very early morning from the midnights. ACTH, it started on surging from the night. And if you see, there is a complete decrease here in the A, that is in a corticotropic releasing hormone, complete decrease in here. So that complete surge decrease will not be in any of the hormones, rather than it is CRH, corticotropic releasing hormone. Peak will also be early and surge will also be early. Same like that, it gets decreased also early. Mild gradual decrease you can see in till the evening, till the night, until the evening, it touches mildly. That is in your adrenocorticotropic releasing hormone. And your cortisol levels peaks always in the morning, after sunrise morning, and it never touches same like your CRH. So this is a pattern which you have to remember. Peak and surge will be shown by your CRH. Till the night, you will have a production in ACTH. It stops and it increases gradually, decreases gradually, will be seen in your cortisol levels. So this is what the graph shows. Next question, a young boy complaining of tiredness and shortness of breath diagnosed with anemia that shows microcytic hypochromic anemia with a normal count of WBC platelets and shape of RBC. So there is no problem in the WBC platelets on shape of RBC. So in which means we can neglect sickle cell anemia and we can neglect aplastic anemia. So this is a microcytic hypochromic anemia that is shown in megaloblastic anemia. What is megaloblastic anemia? In which your vitamin B12 and your vitamin B9 deficiencies will be there. Okay. So if until and unless if all are normal, if suppose they say platelets are decreased and any bone marrow findings, we can think about aplastic anemia also. So sickle cell anemia shape is redefined. Blood loss anemia, there is no history of blood losses that is given, right? Yeah, only B12 will never come under microcytic. It is a macrocytic. As such, that's the reason we have mentioned here megaloblastic anemia. As such, hypochromia is concerned. Ideally, is a what to say controversial question, but once it has been asked, vitamin B12 plus B9 involvement can lead to a hypochromic anemia. Okay, if only vitamin B12 is given, or else if they ask about macrocytic, then you can go with an answer of vitamin B12 deficiency anemia. Here we can have a rule out options, no? So we are going with an option of megaloblastic anemia. Okay. The next phase, plateau phase in cardiac action potential. So we know that there is a plateau phase in cardiac action potential. Very right. Very right, very right. That is L-type calcium channel. Whenever action potentials are there, there will be two things. One in your nodes and the other one in your cardiac muscle. You will have action potential, isn't it? So always, you know, there will be SA node, then it goes to AV node, then it goes to bundle office, then it goes to branches of the bundle office, then it goes to Purkinje fibers. And fibers are the fastest, that also we know. Fastest, how fast is it is? It's 4 meter per second it goes. That fast it is. That fast it is. And please always remember, in this action potential, resting membrane potential is minus 90 millivolt. And spike is also there, that is plus 20 to plus 30 millivolt. They will have a spike. Means they will be increased. And when you will have this waves that is going to start, see, here there is a sodium channels that have a sodium influx, due to which you will have a depolarization, which is a normal thing that you know already, right? Then you will have a first rapid repolarization phase. Rapid repolarization phase, that is a phase 1. Here it is a phase 0. Phase 0, phase 1. This is because of this spike. Because of this spike. This happens due to K plus channel open. We all know that always repolarization happens because of the channel open. Channel open. Now, the phase 2 happens here is a plateau phase where potassium will go out and calcium will come in. Especially by which channels? Especially by long acting, that is L channels. L channels. This is what asked in the question of plateau phase. Then there is a fourth phase. Then there is, sorry, this is the second phase. Then there is a third phase. Then there is a third phase in which late repolarizations are there, where K efflux means potassium efflux is more by potassium channels. That too potassium rectifier channels. Potassium rectifier channels. Very, very important. So this is what happening there. And main stuff which you have to remember is L channels are involved in the plateau phase. And their resting membrane potential is minus 90, spike is plus 22 plus 30 millivolts. Now coming to the last two questions. Type 1 glomus cells we have already discussed this. Whenever our cells are considered, whenever our carotid and iotic bodies of chemoreceptors are considered, this iotic bodies will be having a O2 sensitive K plus channels, especially by the type 1 glomus cell. We have type 1 and type 2 glomus cell, in which type 1 is importantly known. Fine. The next thing, this is about the NREM and REM sleep. First, I'll say small difference in the NREM and REM sleep, the final differences, and then we will come to the question. So few differences in NREM and REM sleep. This NREM will always happen in a inactive mind. Always the active mind will have REM sleep. Here theta and delta waves are there. Here beta waves are there. In NREM people, there will be little or no memory at all. But here there will be complete memory formation. Memory formation. We have a neurotransmitter also, that is a norepinephrine. In our NREM, sorry, in our NREM we have acetylcholine, serotonin, and GABA. These are our neurotransmitters. But in our REM, we have norepinephrine as a neurotransmitter. Always remember about the time. In NREM, adult will always have a non-rapid eye movement sleep, 80%. But a newborn or an infant will have 20% of NREM sleep. But REM, adult will have 20% REM sleep and newborn will have 80% of REM sleep. Okay, so very important to remember the difference of this NREM and REM. Okay, so one more thing I wanted you to mention about the stage of NREM. NREM stage 1, where there is a light sleep. Here in EEG you can see theta and alpha wave. In NREM 2, you can also see light sleep, but 40% of the sleep cycle is by this only. Especially, also theta and alpha waves are there. You can able to see a hallmark, that is a sleep spindles. This is your sleep spindles and K complexes. Why you are having this? Because you have a sensory stimuli always. Whenever you sleep, if someone touches you, you have that stimuli, right? So that's the reason you have this skin complexes and sleep spindles. Whenever someone touches you, you will be able to recognize that in which you will be in a NREM stage 2. That is what asked in the question, K complexes and sleep spindles. There is also NREM stage 3 where the deep sleep. The light sleep is whenever you go to sleep after the preparation or in a day, whole day you have been studying, you're going to sleep first, that will be a light sleep. Then you will be in a bit 40% of the sleep cycle, good mode, where you will say to the people whenever they wake you up, just now I have gone to a deep sleep. That is what the third sleep, that is a deep sleep. D for D, that is your delta wave occurs. Delta waves occurs. And that too occurs for the first time. That too occurs for the first time. There is also NREM stage 4. There is also NREM stage 4. That is your deep sleep and a slow wave sleep. This is the phase when you keep an alarm for morning 5 o'clock And if you don't remember that you have kept an alarm and you don't hear that you have kept an alarm, you sleep till 10 o'clock. But if you want to wake up at 5 o'clock, that is what happens in your NREM stage 4. Okay. But if I say here also, you can see the delta waves. Wherever you see the deep sleep, you can see the delta waves. But who is going to have more? Your stage 4 is going to have a maximum of delta waves. Okay. There is a complaint nowadays, clinical feature nowadays, that is called as teeth grinding. Teeth grinding. That's called as bruxism. It is also seen in your stage 2. Remember, B is the second alphabet. Stage 2 is also a second one. Second number. So this is what bruxism happens. So this is all about your NREM and REM. Important points are covered here. And regarding the graphs and stuffs, much more are there to cover. But still, these are the few very important steps which you have to keep in mind. Last final question. Here I'll say about few reflexes, very important reflexes. 4 to 5 reflexes I'll explain you on the whole. That's why I was been waiting till this. Which of the following is not a component of pulmonary chemoreflex? Whoever sleeping now, I don't want you people to sleep now. At least be awake. I'll explain about the few reflexes, because always in your exams, directly or indirectly, you are being asked. Reflexes are being asked. So as far as pulmonary chemoreflex is concerned, what's being asked here? What is asked here? What is the answer here? Any other answers? I can able to see B. Why rapid breathing? Everyone are giving rapid breathing. C, bradycardia, hypotension. Which is the answer here? Which is not a component? They are asking not a component. Anyone else? Yeah, Aftab is right. That is A. Apnea is not an answer for here. What does this pulmonary chemoreflex says? What does this pulmonary chemoreflex says? Anyone know what is the triad of this pulmonary chemoreflex? Triad of, or what happens in this pulmonary chemoreflex? Please remember, answer is apnea. Pulmonary in the sense it involves lungs. Always lungs, whatever stimulus happens, involvement will be from the vagus nerve. If vagus nerve is involved, there will be rapid breathing, there will be bradycardia, and there will be hypotension also. There will never ever be apnea in vagus nerve involvement. Okay, so this is what involved in your pulmonary chemoreflex. There is one more important reflex, that is Cushing's reflex. What is happening in your Cushing's reflex? Anyone know what's the triad in the Cushing's reflex? Heart rate increases, blood pressure decreases, and there will be periodic breathing. There will be not any rapid breathing. There will be periodic breathing. Please remember that. And next reflex, that is a Bainbridge reflex. There is a Bainbridge reflex. What you have to remember in Bainbridge reflex? Heart rate will be increased. Can anyone say what is meant by Bainbridge reflex? What happens in Bainbridge reflex? Can anyone say what happens in Bainbridge reflex? What happens in reflex tachycardia? Okay. Then what happens? Why we call it as Bainbridge reflex? This Bainbridge reflex question is asked in August 2022. Anyone else who can able to try and answer Bain bridge reflex? Okay, central venous pressure is increased. Why? What is the reason the name bridge came here? Bridge reflex. Okay. Atrial distension with increase in central venous pressure, then see, you are right. There is a distension in atria. See, for example, there is any stretch that is going to happen in atria. Your stretch receptors get activated in atria. In atria. So what it will show, it will give a signal to it will give signal to the vagus nerve. It will give a signal to vagus nerve. So further, this obviously increases the heart rate, right? It increases the heart rate and the force of contraction of heart can also increase. This Bain bridge reflex connects your both pulmonary and cardiac reflexes. Connect your both pulmonary and cardiac reflexes, especially this atrial distension. You have to notice that. And vagus nerve is also getting signals. Just because of that, heart rate is getting increased. One more reflex, that is Bezold Jerish reflex. Bezold Jerish reflex. Anyone know what is Bezold Jerish reflex? Your vagus nerve, but the C fibers are activated in the vagus nerve, especially in the cardio and the pulmonary region. Cardio and the pulmonary region. So remember in the Bezold, yeah, it is connected. Apnea, blood pressure decrease, heart rate increase, that is right. But Kishan, it will happen in your J reflex. Okay, it will happen in your J reflex. Apnea will be there, brady will be there, and also you will have in the C reflex. You can remember by this means hypo ABC. Very right. Apnea, bradycardia in C fibers. This is what we are seeing in Bezold Jerish reflex. Hypo in the sense there will be hypotension. The first ever reflex that is showing apnea. That's your Bezold Jerish reflex. Very right. Okay. And there is also one more reflex, that is J reflex. That is J reflex. Your juxtacapillary reflex, which you have said that heart rate is going to increase. Why? Because your tidal volume is going to get decreased. Tidal volume gets decreased and heart rate gets increased. So this is the main part of how all the reflexes happen. Same like this, we have reflexes in GIT also, we have reflexes in RCDS also, we have reflexes in respiratory system also. Now I had a chance to mention all of the reflexes in cardiac part. Maybe the second part of our revision happens, I'll mention all of our reflexes in respiratory and GIT part as well. I hope this session is useful for you. There might be not any elaborated discussion or conceptual discussion which I would have given just because of this time lapse. If any doubts, you can ever contact, or you can ever anytime ask within doubts in any of the platforms, either in our group or in any of the platform which you use for a AFMG. So thank you. Thanks a lot.
Thank you, ma'am.
If anything else, you can just ask.
Ma'am, what's your channel on Telegram?
channel, our AFMG group Telegram channel is there, right?
Okay.
Yeah, in that you can ask. I'll try to answer all of your questions or any doubts in this session. If you have, then also we will try to clear it out. So have a good day and sorry, have a good night. Try to cover it up and have a
You too,
revision of
ma'am.
all the stuffs which we have seen today. Thank you.
Khatam. Tata. Bye bye.